Stand for invocation. Dora, could you lead us, please?
This day, and Father, we thank you for the opportunity that you have given us to gather here to make decisions for the betterment of the Cherokee Nation. And Father, I just pray for each one that's here today as we travel home to give us safe travels. Father, we ask for your guidance in the decisions that we make. For us in Jesus' name, amen.
Amen. Roll call, Shelley.
Yes, sir. Mike Dobbins.
Here.
Dora Petzkowski.
Here.
Sasha Black Fox Qualls. Here. Danny Callison. Here. Julia Coates. Joe Deere.
Aye.
Kevin Easley.
Here.
Lisa Hall. Here. Johnny Kidwell.
Here.
Daryl Legg.
Here.
Cody Poindexter. Joshua Sam. Mike Shambaugh. Melvina Shotpouch. E.O. Smith.
Here.
Kendessa Teehee. Kendra McGady. Here. Do you want to be a member of the committee? Yes, please. We have a quorum.
Okay. Thank you, Shelley. If you've had time to look at the minutes, I certainly would entertain a motion to approve the minutes. Motion is second. All in favor?
Aye.
Okay, on to reports from the Claremore Service Unit. George Vallier. Welcome, George.
Good afternoon.
Good afternoon.
I was going to give you a rundown on our COVID numbers. We had in August we had 83 positive cases. September we had 188 positive cases. And so far today we've only had one positive flu case. And then I noticed on the morning that whooping cough is at the forefront now, and we've had 3 positive cases of whooping cough. None hospitalized, but we had 3 cases. Finally, we had next Thursday, the 24th, is our Employee Appreciation Fall Festival from 4 to 6 p.m. that Thursday. Invite everybody up to come up and meet the employees and hang out with them that day. You have your report, my report in front of you, and I'll entertain any questions at this time.
Questions for George? See none. Thank you, George.
You bet.
Okay, from Cherokee Nation Health Services, Dr. Steve Jones.
Good afternoon.
Hello.
All right. Well, the report's in your packet. If you have any questions on that, we can get to that in a few minutes. I have a few other highlights I want to talk about before we get to that. Construction is moving on schedule, and if you haven't been by either the hospital or Salina Clinic or and seen some of the progress they've made, you should drive by and see it. It looks fantastic. And like I said, we're on schedule, so everything is moving well right now. Of course, we're moving into the winter months, so you never can tell how weather will affect us. But right now, everything's great. We talked about hospital census last time, so the question was asked about hospital census offline. I told you I'd get those numbers for you for the last year. Our census is 33 out of 50 beds, and those beds, we didn't really calculate in turnover time. That's just a raw number. So 33 is our daily average census over the last year. Contract spend on, I think Counselor Qualls had asked about our nursing and contract spend that we had over the last few years. Contract spend has been reduced by 60% over this last year. We're starting to see a workforce stabilization as things are starting to settle down from all the travelers and the things that were going on with COVID. Recruitment's starting to increase. We've also seen some better processes in HR that's allowed us to onboard a little quicker, so we're not losing those applicants in the process. So all those things are contributing to that, and we're seeing a big reduction in our locums. Vaccine efforts. So as you know, we're entering flu season. We have a list of all the events that we are currently on schedule on the website. And if you go to Cherokee Nation, go to the website, go to Health Services, and then you'll see Community Vaccine Clinics. Click on that. It gives you the list of all the dates and the events for this year. Now, we are adding to some of those when we get special requests to do that. But currently, that's the ones we have scheduled right now. We have been able to see a huge increase in our vaccine efforts this year. Last year at this time, 2 weeks in, we were at 3,562 vaccines given. We're at 6,146 this year in 2 weeks. A lot of that is due to our new texting platform, the Artera platform. I told you about that a couple of months ago, how we're texting patients now. We've moved into the current requirements or what other health systems are doing where we're communicating through text. So when we find patients that are in that area, we're texting them, letting them know about the event, and then when they do come to the event, they'll get a text following up saying thank you for participating. So it's a really good platform, and I think it's really helping in this effort. So the last thing I want to talk about is the Star Awards. Now, you guys have gotten an invitation. Hopefully some of you have already RSVP'd. That's coming up, not this Saturday, I think the next one on the 26th is, October 26th. The Star Awards are a recognition of employees by their peers, okay? And that STAR stands for Special Thanks and Recognition. It's a program we do internally, that we have a committee set up specifically for that. Employees can nominate other employees throughout each month. Those monthly nominations roll into a quarterly award, and then those quarterly awards roll into an annual award. And everybody that's nominated for that annual award gets to attend the banquet, and we will find out the winners at that banquet. So please, if you can participate and come and participate with us, do that. Again, the nominations are from their peers, and they're following our 7 values, which are self-determination, excellence, respect, visibility in the community, integrity, compassion, and equity. So those are the qualifications for being nominated. If you can attend, please do so. We'd like your support in that, and I'm sure the employees would love to see your support as well. So I was charged to announce that from the committee, so I've done my job. So hopefully some of you will be able to attend and participate with us. That's all I have for my report, Counselor, so if any questions, be glad to answer.
Cody?
Could you hang around afterwards? I got a question for you.
Sure, absolutely.
Eddie?
Dr. Jones, you mentioned 34 beds on an average that they have here at Hastings. Is there any way to tell us, for example, through contract with the other hospitals and stuff, actually how many people we have in the hospital on a monthly basis? Or
That's on a daily basis. On a daily basis, we have 33 admissions per day on average.
But that's not counting if you're sending them to Tulsa or you're sending them to Hillcrest or somewhere like that.
No, if the acuity rate is at a higher level, or they need specialty care, or in some cases when our hospital's full, we do transfer patients to where the bed's available. Here in the last few months, I watch that report every morning. Our hospital's been full a lot the last few months, so there's been some transfers as a result of not having a bed available. That'll be rectified whenever we get into the new hospital, but right now that's some of the things we run into with the number of beds that we have.
So with the new one being built, we're going to not have to contract so many of them out and send them off. We'll be able to take care of them ourselves.
Absolutely, and the whole idea is to keep people close to home. We don't want to send people off where they lose contact with their support system. That's the downside. A lot of people, when they get sent out, their family can't travel with them. Their family can't take off work and be with them when they're admitted in Tulsa or Joplin or someplace outside of our system. And so that's one of the things our primary emphasis is on, keeping people close to home as we can.
Thank you.
Yeah.
Sasha?
Thank you, Chair. First, I just want to recognize and acknowledge the Cherokee Nation Harm Reduction Program. I attended the RAP program's gala on Saturday evening, and they received the Community Engagement Award. So congratulations to their program and Mr. Cox. That's a wonderful achievement.
Yeah.
On to some questions. I have a couple, so I'm sorry.
Okay.
So back in February or March, approximately whenever that was, we talked about the prescription mandate. And during that meeting, I was assured that the providers were going to be able to use their discretion on whether it was going to be 30 or 90-day prescriptions. So I've recently encountered some patients. I've been given their permission. So 18, 19 years old with, say, birth control. They're only getting a 30-day prescription, whereas their provider's still issuing a 90-day, but the pharmacists are declining to fill that 90-day script, saying that they have not received authorization from leadership to go ahead and issue that 90-day. Is that something that we can work on or send to those pharmacists to convey that communication that they do have that authorization to do so and the autonomy as providers to issue those prescriptions?
That is totally up to the provider, and we honor what the provider says, but if you'll give me the specific one, I'll have someone look into it.
Okay, thank you. Next was the same-day clinic at CNOC. When we had discussed previously, some outlying clinics, they do the 20-minute increment slots or appointment slots. CNOC was going to allow some walk-ins. Is that still the case, or has that changed?
We do have a same-day clinic that's at CNOC, yes.
Do they allow walk-ins, or are they being sent to the ER?
Depends on the overflow, how many people we have walk-in, and how much time is there. So we only have a limited number of providers, and they will see as many patients as they can possibly see. If it gets to a point where a patient's going to be waiting way too long, then we're going to use that overflow. That doesn't get used very often. It does, on the weekends it gets used because we don't have same-day clinic or urgent care clinic on the weekends. It does fall into the ER on the weekends and after hours.
Are we seeing that affecting the ER wait times? I mean, personally, I've experienced that, and it was a long wait time.
Not that I'm aware of that be any different than any other time, because we do watch our wait times, we do watch that time cycles. There are times when the ER is busier than other times, and that just happens, and you can't predict that.
No.
So that will happen, but historically, it's not affecting those ER times. We're staffed accordingly. As a matter of fact, what we've been told from our director is that it's been better with the urgent care being moved out. So patients are learning when it's appropriate to go to one, to the other, and they're kind of self-determining which way they should go.
Okay. Last question, I'm sorry.
Okay.
So it was brought to my attention an incident regarding a service animal there at the clinic. Since then, there's been a new policy released last Tuesday, I believe. Was our AG's office consulted in implementing this new policy?
Absolutely.
How are we notifying patients that have service animals? And can you elaborate and provide those details to us?
Yeah, so when a patient presents with a service animal, if there is anything that's going to inhibit them from getting care, we are going to be very judicious in how we enforce that policy, especially in the beginning, as patients learn what's appropriate and what's not appropriate. That policy had been being abused quite frequently and not being followed the way it was written before in some circumstances. So we just decided we would tighten it up and give our security officers what they needed to be able to enforce that policy when patients came in the door. And our administrators, because it is going to be flexible according to the administrator and how they perceive the situation on a case-by-case basis.
Okay, all right. Thank you.
Any other questions for Dr. Jones? Speaker?
So this new policy, is it going to mirror federal policy? Or are we going out on something different on our own?
It's a little stricter than federal policy in the fact that it does try to keep our patients and our staff safe. There is additional requirements that just to make sure that a service animal is in fact a service animal and not someone's pet they're bringing in and calling it a service animal. We've had some situations in our clinics where staff has had an aggressive animal towards staff. We had a situation where a security officer got bit. We have disruptions to the clinic. If it's a true service animal, then they are well behaved. They're not barking. They're not intimidating or bothering other staff or other employees. So it does tighten it down and make sure that a service animal is truly a service animal.
So how many of those type of things do we have generally service animals coming into the clinic?
I don't know the answer to that, but we do have all kinds of instances that happen throughout. Over the last few months, it's been more prevalent. We had someone try to bring a monkey into the clinic. And then
Service monkey?
and then went outside and stuck it inside their shirt and tried to come back in. We had someone bring a raccoon into the clinic. So there are things that we just can't have in a health center. And that policy is going to strengthen that, our requirements, and give our security the ability that when they do see something, they can ask the right questions to determine, is this a service animal? If it is a service animal, by all means, we want them to have full access. They're going to get a badge that they're going to put on themselves, so everyone in the clinic knows they've been cleared as a service animal, and they can go wherever they need to go. But if it's not a service animal, we need to know that. We don't need to have situations that put either staff or patients at risk.
Yeah, I know, just that, federal law really says you can't even ask,
Right.
if it is or not. And you certainly don't have to take paperwork. I just wondered how ours was going to
And I will say that with, the AGA, the AG can probably talk more about this than I can, and absolutely in more legal terms. But as far as a sovereign nation, we choose what we abide by with respect to the ADA. And
Sure.
their,
And I hope we
their
use common
regulations.
sense, too, when we do things like that, especially if the animal looks the part and it isn't giving anybody any problems. I mean, that's kind of
That's why we've given full flexibility to the administrators and to the security to make that determination on a case-by-case basis.
Yeah.
We don't want to inhibit anybody from getting any kind of care or treatment, but we also have an obligation to keep our employees and our other patients safe.
all right. Thanks, sir.
Junior?
On that officer got that bit, was that a Chihuahua, Betty?
No,
I
I
heard
don't
it
think
was.
so. I mean, that may be a different situation I don't know about, but the one that happened at CNOC was not a Chihuahua. Matter of fact, he was lucky because he had his baton and was able to hit the dog and get it off of him, so.
That you need a counselor? Go ahead. Go ahead.
I'm in public transit, and we deal with this all the time. We don't have the same flexibility to massage the ADA law, but I commend you, and I understand the challenges with this, and I certainly appreciate that you don't want to keep anyone from having their emotional support animal, but I have to admit that a monkey is a first for me. I've had a emotional ferret on my bus before, but never a monkey. So I totally appreciate what you're going through and appreciate you making this priority for our medical facilities. So
Thank you.
Any others? Julia?
I am a little concerned about the flexibility that is being lauded here, because that's not generally what policies are for, Policies are to set a baseline so that everybody is in fact treated the same. And I think that when we start, leaving it to the individual discretion of, whoever may be on duty that day and what their own fears and biases and whatever may be, that we're kind of actually undermining public confidence a little bit in a way, the confidence that people will be treated without bias. But the second thing I want to say is that an emotional support animal is different from a support animal, right? That is, and so that's a distinction that has to be made, because nobody makes a monkey a support animal, right? That's an emotional support animal, and so I think right there we've got a basis, just for denying things like that, but I think that when we're talking about an actual working, well-trained, and you said they are well-trained, right? That's and they're dogs generally, right? I don't know, maybe other people know, but I don't know of any other type of animal that does provide actual, necessary medical support, or assistance to individuals. But I just, I think that's an important distinction that we have to make between emotional support. No, you can get a certificate online for that. That's a totally bogus category in most instances. But a real support animal, they'll have the little vest or the big vest, as the case may be. That right there is usually a very, very good marker. And if people don't want to bring in documentation, because not everybody carries that around, but I think generally if they're using that animal in a support role, as they're out in public and so forth, they will dress it appropriately, don't they? And that's a pretty good clue for us right there. But I understand, about the dilemmas and people trying to slide things by, under the guise of being emotional support. But I think that I am leery about policies being applied, inconsistently. I really am. So just make that remark. I don't have suggestions as to what the response, or what the corrective may be, but that one concerns me.
May I
Yeah.
respond to that?
Sure.
So there is a difference between a support animal and a service animal. And as I said, when someone is determined to have a service animal, they'll get a badge that says service animal, and they'll be able to go anywhere in the clinic. We don't want to inhibit anything. The flexibility that we saw is because this is a new policy and it is implemented, the ultimate say, and we wrote this in the policy, the ultimate say at each facility will be the clinic administrator, because they know what's going on at their clinic, they know their patients, they know their community, and they can make a case-by-case basis, especially in the beginning when we're starting to implement this policy, because at the end of the day, we don't want to inhibit somebody from getting care. And we don't want to send somebody home because they're in violation of a policy when they need the care that day. So that's where that flexibility comes in. We're going to be very flexible in the beginning, so we go through this educational process, and the last thing we want to do is inhibit anybody from getting the care they need, whatever service they need that day. Because we've worked so hard to get our no-shows down, to be efficient with our appointments. We want to make sure our providers are being efficient with their appointments, and a missed appointment is an appointment someone else could have. So we don't want someone to have to miss an appointment because of a policy they weren't aware of. So that's where the flexibility comes in. I just want to make that clear, and that's why we gave it at the local level to each clinic administrator. That's what we pay them to do, is to make decisions on their clinic, on their day-to-day operations, on what's best for their clinic. Now, overall, if there's issues that continue to arise, we'll address that. But right now, that's the intent of why we've given some flexibility to our clinic administrators.
And I understand that, but I hope you also understand my point. Flexibility is something that is frequently abused, when policies are made with a greater level of flexibility than is perhaps wise. So I hear you.
Yeah,
I hope you hear me.
Yeah, absolutely.
Thank you.
I understand.
Any others? Dr. Jones, could you just, I think 5 of us were there for the meeting with the Claremore Indian Hospital employees. Could you just give a brief overview on what the content of that meeting was, what we achieved? I know you and Chief Hoskin primarily drove that meeting.
We did have a town hall with the employees in Claremore, and it was also attended virtually by some employees that weren't able to attend in person. The intent was to attend in person where you could ask questions. The main emphasis was to dispel rumors and to put some of those rumors aside. It's very early in the process. There was a lot of things floating around, a lot of assumptions, a lot of rumors, and the employees got to ask questions of myself and of Chief Hoskin, and we addressed those questions. So I felt like a very good meeting. Had a lot of employees come up after the meeting and talk with us one-on-one. As a matter of fact, I don't think I got out of there until around 6 o'clock. So it was well received. I think it was a good thing that we did it. I think it put a lot of rumors aside, and people can now get back to work and know that we're going to be working toward common goals over the next year. We're just now starting, it's the tip of the iceberg, we're just now starting to have coordination meetings so that we can get the information we need in order to make good decisions moving forward on how we can help and how we can hopefully expand services there. We want to expand access. We want to make sure that the patients that live in that area have a seamless one healthcare system and not having to navigate two systems as they are now. And so how are we going to be able to do that? That's over this next year. Those are the things we're going to be asking and answering, bringing things up to date. You know, one of the things we've determined is, and because Indian Health Service they've made a decision, but I don't think they have an implementation for a date when they'll have a new electronic health record. Fortunately, they chose Cerner, but we'll be through this process before they ever get to the day of implementation. So those are the kind of things we've got to figure out. How do we bring their IT level up to the same as ours where they can communicate? Because right now they can't communicate. They're still on RPMS, which is an old system that we got rid of many years ago. So those are all things that we're working through. There'll be a lot of things that we'll have to, obstacles we'll have to come up against as we go through this next year. But the main thing was to put anxiety away and rumors away and really address the questions and let them ask questions directly of us so we could give direct answers, and I think that was accomplished.
Well, I would agree. It seemed like most of the time was spent dispelling rumors, and so I thought it was very productive in that regard.
Yeah, absolutely.
Mike?
So would you say that the employees seem to be more positive than negative about it? Do you think that they?
The ones that spoke to me after the meeting and came up one-on-one were very excited about the opportunity and about the change that's going to happen. So from my own personal experience, I would say yes, it was a very positive thing, and the employees that I talked to were very positive. You know, and like I said, there was a lot of negativity and a lot of rumors out there, and we were just trying to address those on a one-on-one basis and let people ask questions in a format where nothing was edited. It was all raw and open, and you got to ask what you wanted to ask.
All right, thank you.
Anybody else? Sasha?
Just for clarification, on the prescriptions, instead of us sending a multitude of emails regarding individual patients, is that something that you can relay to the pharmacist?
I can check on it, but if you give me a specific one, I can look into it and see what the situation was with that one. Because the narrative right now, or the directive right now, is it's up to the provider. We're not telling providers how to practice medicine. We're telling them that if it's their choice to go with the 90-day because they feel like that's best for the patient, then they have that option to do that. We're trying to not tell people how to practice medicine. So I need to see why this patient's saying that they weren't. If the provider truly did give them a 90-day, that order wasn't followed. So I need to find out why that order wasn't followed.
I mean, I can tell you from my own experience at Three Rivers, the pharmacist specifically state to me they have not been given authorization to issue 90-day prescriptions.
And their authorization comes from the physician, because that's who writes the order to the pharmacist. We don't dictate the order to the pharmacist as administration. So I need to know, I will check into it and see if there's a miscommunication there, but to my knowledge, this has been, in place for several months now. Now, I will say that we're going to phase this in. There's different phases coming in for 90 to 30 day, and we've just done one phase, which was a very small portion of the population because we didn't want to overwhelm our pharmacist.
Okay, thank you.
Okay. Darryl?
I got mine changed to 90 days after that last meeting, all except for one, because they're testing my levels on a different one. But if they stay the same, then they're going to award me a 90-day on that one also.
And that's the intent.
Yeah.
Exactly a good example of the intent. Whenever you're testing levels and trying to change medications, if you give a 90-day, you're probably throwing 60 days away. And that 60 days worth of prescriptions could have gone to another patient. So we've got to be, in this day and age, as many patients as we see over the course of a year. Our formularies are very expensive, and we've got to be very good stewards with that money and with those formularies. We can't be wasting medications that we could be using for someone else.
Okay, thank you, Dr. Jones, for that report.
You're welcome.
From Public Health, Lisa Pivek.
Hello, everybody. Good to see you today. Always a pleasure. Nice little Halloween decorations back there. Make it a little friendlier. Yeah, it's smiling at me, so I'm happy about that. You got to mimic the Okay, I just have you have my report in front of you. I have a couple of things that I might want to highlight through there. As you've been hearing, it's Summer Electronic Benefit Transfer Program this year was the first year with the new program rules and guidelines and the expansion. We ended up serving, after all the different numbers have come in, around 107,000 children. We've already started planning for next year. We have looked at all of the things that worked well, the things that didn't work so well, and provided written comments back to the USDA about their interim rules and regulations for this program. So hopefully next year we'll be able to make some improvements, be able to do some new and innovative things as well. We're working on all kinds of projects for next year to hopefully increase redemption rates, and which we don't have this year's yet. We will pretty soon. During the month of November, I wanted to highlight a couple of things. November is a big month for community health promotion. We are partnering really closely, taking the lead with Health Services, taking the lead with Diabetes Awareness Month. So both Health Services and Public Health have events going on during the month of November. You will start to see those, I would say, within the next week or two, probably this week, come out a list of things that are going on during that month. And they're doing most of the clinic, all of the clinic work. We're doing some of the community work, and hopefully looking to partner for more things in the future. It's also Great American Smokeout Month. So in that, I wanted to highlight that if you've looked at some of the smoking cessation numbers, you will see that they're starting to increase as we go through time. And one of the big highlights that I wanted to highlight from this year is we had 31 employees stop smoking, which doesn't sound like a lot, but it actually is quite a big number. So wanted to highlight that. And those are my highlights. I'm happy to answer any questions.
Go.
We had talked before about diabetes and health and wellness, like a rewards program. Did we ever get something going, like a point program for kids walking, stuff like that?
We're still working on the point program, being able to offer it across the entire reservation and being able to access that many people for that particular program. We are still working on our offerings for diabetes prevention, though, and have acquired some staff for enhancing our nutrition programs just within the last 2 months.
Yeah, I figured since November, maybe we could start with just doing a simple month.
Yes.
So, all right, thank you.
Anybody else? Junior?
What was that number on the cards?
107,000.
107? I wonder if our governor's seen that figure.
I don't know.
We ought to send him a little card, tell him.
I'll let you do that, Ian.
Put on your Christmas card list.
Yeah, there you go.
Okay, thank you, Lisa.
All right, thank you, guys.
Under old business, I see none pending. New business, none pending. Announcements, the next meeting is tentatively scheduled for Tuesday, November 12th at 11 a.m. Are all the meetings in November, are we just having one day meeting for all? Okay, so it's going to be same thing next month. Okay, all right. Any other announcements? Sandra?
We are having a 5K and fun run, the Haunted Hustle in Hulbert, Saturday the 19th. The 5K begins at 9 a.m. and the fun run at 9:05. Registration begins at 8 a.m. if anyone would like to join.
Okay, thank you, Sasha. Any others? Okay, I need one more motion. Is there a second? All in favor? We're adjourned.